I'm Dr. Fakir Abadi, and this is Opportunistic Infections in Adults. Opportunistic infections typically do not affect patients with an intact immune system, so the name opportunistic refers to the fact that these infections take advantage of immunocompromised patients. Immunocompromised patients not only can they get opportunistic infections, but they can also have non-opportunistic infections like other people. So infections like UTIs, community-acquired pneumonia, skin and soft tissue infections, etc. Which patients are considered immunocompromised? In general, advanced HIV, meaning a CD4 cell count of less than 200, as well as cancer patients receiving chemotherapy that cause myelosuppression, including neutropenia, and those patients who receive immunosuppressant therapy for either autoimmune conditions, as well as those who have received transplant, and that includes both solid organ transplant as well as stem cell transplant. And one thing that's very important to keep in mind is that use of systemic corticosteroids at a dose equivalent to prednisone 20 milligram per day or more for at least 4 weeks is considered immunosuppression because that can affect the T cells. And asplenia. So the spleen has the function of filtering the blood. So specifically, any bacteria that's encapsulated will be removed by the spleen. So that includes pneumococcal species as well as Haemophilus influenzae. And asplenia could be either functional asplenia. For example, patients with sickle cell disease will have a non-functioning spleen, or if it's anatomical, meaning that it was surgically removed, so splenectomy. In this topic, we will focus on HIV-related opportunistic infections, which are those infections that are most frequent or more severe because of HIV-mediated immunosuppression. Now, in general, for patients who are linked to care and who manifest durable responses to long-term ART, survival of patients with HIV infection is currently almost equal to that of individuals without HIV infection. So, in general, these are basically becoming rare in patients with HIV because we have very effective ART. Now, one thing to keep in mind is that HIV-related opportunistic infections do not behave clinically exactly like opportunistic infections seen in other immunosuppressed population. For example, when we talk about toxoplasmosis in HIV, toxoplasmosis manifests mainly as encephalitis, whereas in patients with cancer or organ transplant, for example, it's more likely to be like visceral or disseminated disease. We're also going to talk about pneumocystis pneumonia, which is far more likely in patients with HIV. Yet the same organism often develops indolent disease in other immunosuppressed patients. So here's the problem in advanced HIV. So obviously a normal person has a large amount of CD4 cells. So here on the y-axis we're looking at concentration of CD4 cell count in the blood. And on the x-axis we're looking at time. So a normal person has very high number of cells, CD4 cells in the blood. And once this person gets a primary HIV infection, then these CD4 cells start to go down. And then as time goes on, and this is of course without ART, these CD4 cells start to go down in time. And then by the time it hits less than 350, this is where the risk of some infections go high, including some viral infection like varicella zoster, as well as other bacterial infections like tuberculosis. So these infections occur more frequently. Now these are not necessarily opportunistic, but the rate goes up. Now once you hit the the 200 mark. So if the CD4 is less than 200, that's when the risk of opportunistic infections becomes real. So this is when you get pneumocystis pneumonia, esophageal candidiasis, and then as the CD4 goes even lower, so less than 100, then the number of opportunistic infections go up. So you started to have more incidents of cocci, crypto, as well as toxoplasmosis and Mycobacterium avium complex. So for someone with CD4 cell count very low, specifically less than 200, the immune system is essentially non-existent. And now imagine an HIV patient who starts ART. So if the CD4 count is depleted and then they start ART, then CD4 can start to go up. Now this can result in a syndrome referred to as IRIS. So IRIS stands for immune reconstitution inflammatory syndrome, and this basically means that if you start ART and CD4 cell count goes up, then you start to have symptoms of inflammation. And that's because previously, because of the lack of lack of an intact immune system, the patients are not capable of having that immune response, so symptoms of inflammation are non-existent. So when you start ART and these symptoms suddenly occur, which sometimes can be very severe, this can be due to two reasons. One is referred to as unmasking IRIS, which is basically, if someone already had an infection, but because there couldn't be an immune response to it, obviously there wouldn't be any symptoms. And once you start ART, then those symptoms basically become unmasked. So this is referred to as unmasking IRIS, that you just discovered an infection that was already in the patient. We just didn't know about it because of lack of symptoms. Another one is called paradoxical IRIS. And this is basically in someone who used to have an infection, but the infection is not necessarily there anymore. But the residual antigens from that previously resolved infection might be circulating in the body, and once you start ART and these CD4 cell counts go up, the body will have a response to it. So these are important to keep in mind in someone with CD4 less than 200. Once we start treatment of opportunistic infections, if you start ART at the same time, for some infection, initially it may look like the patient is getting worse, even though you just started ART. And that's typically not a concern because it's just IRIS happening. Now, I say typically there are situations where the IRIS can be severe, specifically when it comes to CNS infections. So, sometimes it might be necessary to actually treat IRIS with anti-inflammatory agents like corticosteroids. The first learning objective is describe the pharmacokinetic and pharmacodynamic properties of anti-infective agents used for opportunistic infections. So trim-sulfa, trimethoprim, sulfamethoxazole combination is by far the most commonly used agent. There are two brand names for it, Bactrim or Septra. And it's available as PO and IV. Most commonly it is used as PO. The IV formulation has very limited stability. So, if you can use PO is used more often. And the adverse profile, you can see that obviously these happen at the same time because trim-sulfa is given often as a combination. Trimethoprim is also available as a standalone drug, but more commonly it's used in combination. So trimethoprim component can lead to anemia, leukopenia, thrombocytopenia, as well as hyperkalemia and hyponatremia. Trimethoprim can also inhibit the secretion of serum creatinine, so it can artificially increase serum creatinine levels without affecting GFR. So that's just an artificial. But the most important is really to keep an eye on the hyperkalemia when it comes to monitoring of trimethoprim. Other adverse effects are not really as common for trimethoprim. For sulfamethoxazole, it's a sulfonamide, and for sulfonamide drugs in general, you want to think about skin reactions. So rash is the most common one, and sometimes it can be severe. So Stevens-Johnson syndrome can happen. It's rare, but it can be fatal. And other skin-related reactions include photosensitivity. And in addition, sulfonamides can also have GI adverse effects, so nausea, vomiting, and diarrhea. And they can also be nephrotoxicity. So together, trimethoprim and sulfamethoxazole, really can cause nephrotoxicity, and this could be a combination of sulfonamide causing nephrotoxicity as well as trimethoprim artificially inhibiting the secretion of serum creatinine. You do need to renally adjust the dose of trim-sulfa. So if creatine clearance is less than 30, half of the dose should be given. We also have sulfadiazine, which is also sulfonamide, so it's very similar to sulfamethoxazole. And we also have dapsone, which is similar to sulfonamides. Now, dapsone can cause methemoglobinemia and hemolysis, especially in patients with G6 phosphate, glucose 6-phosphate dehydrogenase deficiency. So it is recommended to test patients for glucose 6-phosphate dehydrogenase deficiency, and if they have that deficiency, it's best to avoid dapsone. Atovaquone inhibits ATP production by inhibiting the mitochondrial electron transport chain. It is very important to take this atovaquone with food in order to increase absorption. Now, we also have a couple of anti-malarial drugs that are used for opportunistic infections, so primaquine and pyrimethamine. And primaquine is actually contraindicated in patients with glucose 6-phosphate dehydrogenase deficiency, so it's absolutely essential to test patients for this deficiency before we start. And then leucovorin is basically a folic acid vitamin, which is used in combination with pyrimethamine in order to avoid the adverse effects, specifically hematologic adverse effects of this drug. So leucovorin technically is not an antibiotic. It doesn't do anything to opportunistic infections. It has to be given with pyrimethamine to basically avoid the severe adverse effects of that drug. And lastly, we have pentamidine, which is also available in an inhalation formulation, but it is not available as an oral formulation. Now let's take a look at some of the antiviral agents used for management of opportunistic infections. And here we're really talking about cytomegalovirus, or CMV, as the opportunistic viral infection. And because acyclovir, valacyclovir, and famciclovir are ineffective against CMV, we're not going to talk about them. The most common antiviral agent used for management of CMV is ganciclovir. And ganciclovir is basically a nucleotide analog, so it inhibits viral DNA synthesis. It has very poor oral bioavailability, so the oral formulation is no longer available in the US. It's primarily used as an intravenous injection. It can also be injected into the eye. Now, valganciclovir is basically a prodrug of ganciclovir, and this addition of valine group improves oral bioavailability. So it is available as PO, and it must be taken with food to increase absorption. And once it's absorbed, it's basically converted to ganciclovir. So mechanism of action is identical, as well as the adverse effects. Unfortunately, these agents are very toxic. The most important toxicity of these agents is myelosuppression, and this is dose limiting. So patients basically will experience neutropenia and thrombocytopenia, so platelets will drop. Now, fortunately, this is reversible, so within 1 week of drug cessation, neutropenia should be resolved. There's also GI effects, so nausea and vomiting, as well as CNS effects, headache, insomnia, and it can be severe. So seizures and coma have also happened in patients, but is not as common. They can also cause hepatotoxicity. This is, mild elevation of liver enzymes is not as severe as CNS effects and myelosuppression. Some patients can experience fever, rash, anemia, and peripheral neuropathy. Now, cidofovir is also a nucleotide analog, and it's only available as IV because of poor oral bioavailability. Now, this agent is not causing as much myelosuppression as ganciclovir, but it is extremely nephrotoxic. In fact, it is the most nephrotoxic agent used for CMV. It is so nephrotoxic that initiation of cidofovir therapy is actually contraindicated in patients with existing renal insufficiency. And it must be administered with high doses of probenecid in order to block active tubular secretion and decrease nephrotoxicity. And before each infusion, cidofovir dosage must be adjusted for alteration in creatinine clearance or for the presence of urine protein, and aggressive adjunctive hydration is required. So normal saline would be administered before and after the infusion to reduce nephrotoxicity. Cidofovir can also cause anterior uveitis. So basically, this is inflammation in the uveal layers in the eye, and anterior means that this will be in the front of the eye as opposed to in the posterior area. Now let's take a look at foscarnet. So foscarnet is an inorganic pyrophosphate analog, so it is not a nucleotide analog, so the mechanism is very different. So when it comes to cross resistance, this becomes very important. But it does inhibit viral DNA synthesis, so the end product is the same. And it also has poor oral bioavailability, so it's only available as IV, and it can be also injected into the eye. It is also very nephrotoxic, so it's not as nephrotoxic as cidofovir, but it's very nephrotoxic, so it can cause a lot of electrolyte imbalances. So calcium can either go up or low. So, hyper or hypocalcemia can occur. It just depends. The same with phosphate. So, hyper or hypo, whereas magnesium and potassium will often be low. So, hypokalemia and hypomagnesemia. It can also cause GI effects, so nausea and vomiting, and some CNS effects, including seizures, some mild elevation of liver enzymes, as well as some, anemia, fatigue, rash, and leukopenia. But it's not, the leukopenia is not as severe as myelosuppression caused by ganciclovir and valganciclovir. Now, because of this severe nephrotoxicity of foscarnet, saline preloading is also recommended to prevent nephrotoxicity. So normal saline is often given before the infusion. Lastly, we have letermovir that was recently approved, and it is only indicated for prophylaxis in CMV seropositive recipients of hematopoietic stem cell transplant. So it is currently not indicated for patients living with HIV. But I put it here in case in the future it gets approved for use in HIV patients as well. The mechanism is different. So it is an inhibitor of DNA terminase complex. And this is something that's very unique to the virus, to CMV. So basically, because mammalian cells do not have this, there is very minimal adverse effects from letermovir. So it is generally well tolerated. Of course, there can be some GI effects like nausea and vomiting, and it is available as both IV and PO. Now, when it comes to the life cycle of CMV, which is a DNA virus, it basically has to enter the nucleus of the host cell. And once it goes into the nucleus, it needs to do two things. So it needs to do the usual, conversion from DNA to messenger RNA, and then, through translation, have some final products, proteins that are used by the virus in order to make more virus. But also the DNA needs to replicate. so multiple copies of the DNA, and this DNA will also be used with these proteins in order to assemble a new variant and then release it, and the cycle continues. So this, because the synthesis of DNA is important for replication, this is targeted with our antivirals. So the antivirals that we have, now here we have a general figure, so acyclovir and famciclovir are listed, so that's really more pertaining to herpes simplex virus. But for CMV, it's really ganciclovir and valganciclovir that basically act and inhibit conversion from a nucleoside to monophosphate nucleoside. So this is a phosphorylation process that's required for DNA synthesis. So all nucleotides needs to be phosphorylated as part of DNA synthesis. And these agents that are listed here need to be phosphorylated in order to mimic this phosphorylated nucleotide. And these agents are actually phosphorylated by virus-specific enzymes. In the case of herpes simplex virus, is thymidine kinase. In the case of CMV, it's a protein called UL97. So it's UL97 that will phosphorylate ganciclovir, and then ganciclovir phosphorylated by UL97 will be able to block this step. Now, this is monophosphorylated. It will continue to be phosphorylated to diphosphate nucleotide, and this is the step that's blocked by cidofovir. So cidofovir is different because it doesn't need UL97. So if there are mutations in UL97 leading to ganciclovir resistant CMV, cidofovir will continue to have activity against ganciclovir resistant CMV if the mechanism is mutations in UL97. If the reason for resistance is mutation in the DNA polymerase used here, cidofovir will also be resistant. So mutations in polymerase will cause resistance to ganciclovir and cidofovir, and that's where foscarnet comes in. So foscarnet can block the final step. So really foscarnet's use is for those resistant strains of CMV where ganciclovir and cidofovir are no longer viable. Here are the black box warnings for cidofovir. So of course, renal impairment, and there are recommendations from the FDA to reduce the possibility of nephrotoxicity. They also have neutropenia as a black box warning, as well as carcinogenic and teratogenic, and also hypospermia in men. Some of the contraindications include hypersensitivity, serum creatinine greater than 1.5, creatinine clearance less than 55, urine protein 100 or more, and use with or within 7 days of nephrotoxic agents. And these nephrotoxic agents include things like amphotericin B, aminoglycosides, NSAIDs, and also foscarnet. There are some situations where multiple antivirals can be used in combination when dealing with resistance. So there may be a situation where cidofovir and foscarnet might be needed to be used together, but that's actually contraindicated because of the nephrotoxicity. And of course, cidofovir should not be injected into the eye because of the toxicity to the eye.